All right, guys, welcome back. This is Labs Part 2. We talked about hematology in the first part, and so this one we're going to talk a little bit about coagulation studies, which have to do with how fast or how slow the blood clots. And then we're also going to talk about cardiac enzymes because coagulation is relatively short. So I decided I would combine the two. So let's get started. Coagulation studies, our most common ones are prothrombin time, international normalized ratio, activated partial thromboplastin time, and fibrinogen. And again, remember that these values are just estimates. It depends on the lab that you're working in. It depends on the lab reference manual that you pick up. It really just depends, but these are rough estimates as to what we want these normals to be. So let's talk about these individually. First we have is prothrombin time and INR. We abbreviate prothrombin time as PT. A normal PT time is about 11 to 14 seconds. So this is how fast it takes for the blood to clot. So this is the actual time that it takes for a blood to clot. So if you were to cut your arm, normally we would see you clotting in about 11 to 14 seconds. Now, for an INR, we like to see that level less than 1.1. That is considered normal. Now, however, if your patient is taking a blood thinner such as warfarin, we typically want that INR to be 2 to 3. So 2 to 3 is considered therapeutic if they're on warfarin for a regular dose. Now, there are some instances in which case your patient is on a high dose of warfarin because they want to be like supra-therapeutic, and that normal would be 3 to 4. But warfarin has just a very little tiny window of being toxic versus non-toxic, which is called a narrow therapeutic index. And so when our PT and our INR are high, there is an increased risk of bleeding because warfarin is a blood thinner. So we anticipate when we give a blood thinner that it takes longer for the blood to clot. So when these numbers are high, that's an increased risk of bleeding. When they're low, they're at high risk for clotting. So high bleeding, low clotting. These are often checked when a patient is on blood thinners. We don't see PT drawn as much as we see the INR. The INR tends to be the gold standard when it comes to, is this patient at a high risk for bleeding or not? Moving on to the activated partial thromboplastin time, or APTT for short. An APTT is about 20 to 30, 20 to 40 seconds. You'll see something different in each reference manual that you pick up. And basically, this assesses the actual proteins of clotting factors. So it determines how well these proteins do their job to help clot. It evaluates how well the patient's blood is actually clotting. A prolonged APTT means that bleeding takes longer, or bleeding is more common and it takes longer to clot, whereas a shortened APTT level is a shorter time to clot. So the longer the time is, the longer it takes to clot, and so your patient is at higher risk for bleeding. Now, our APTTs are very, very, very common in heparin therapy. Most of the time when our patients are on some sort of heparinized therapy, we expect their APTT to be about 1.5 to 2 times the normal level. But today's focus is just on normals or abnormals, not necessarily the details of each. The last type of coagulation study we have is called fibrinogen, and fibrinogen is roughly 1.8 to 4 grams per liter. This evaluates the level and function of a specific coagulation factor. So this is very specific to fibrinogen only, and this reflects how well the fibrinogen works in the role with clotting. And so again, not really a very common test per se. We usually stick with our PTTs and INRs. However, there are some, how can I say it, conditions or disorders that require a fibrinogen level. And again, this is outside of the scope of this particular conversation. But whenever you get into hematological disorders, whether in your program or if I ever create one, we will talk more about where fibrinogen plays a role. So let's talk a little bit about cardiac markers. These, as they say in the name, are indication of heart function and or heart muscle deterioration. So we have a couple here. We have something called creatinine kinase, or CK for short. It's normally 25 to 200. It measures the level of creatinine kinase in the blood. CK is actually a protein / enzyme that is found in skeletal muscles and within the heart. It is used to detect rhabdomyolysis or muscular dystrophy. So whenever CK is elevated, you can rule other things out beyond a heart. So that's the downside of using CK for completely a cardiac marker, because it is also found in skeletal muscle. So just because we have an elevated CK doesn't necessarily mean it's the heart, but it could be rhabdomyolysis or muscular dystrophy. Okay, sorry about that. We had a barking interruption. Okay, so we're moving on to CKMB, or creatinine kinase MB. This is normal 3 to 5% of total CK. So if total CK is 25 to 200, a normal CKMB should be anywhere from 3 to 5% of that total CK. Now, what is CKMB? It is actually an isoenzyme of creatinine kinase, and it's primarily found in the heart. So an elevation in CKMB could indicate a heart attack, heart disease, or good old angina or angina, depending on where you're from. And so an elevated CKMB, heart attack, heart disease, or angina, because it is primarily found in the heart. Now, our next one and our last one that we're going to talk about today is troponin. Troponin is a normal of 0.1 or less than 0.1. Now, what is troponin? Troponin is a group of proteins that are found in skeletal and heart muscle fibers that regulate muscle contraction. So troponin can be found in other places, but it has become our gold standard for diagnosing a heart attack. And so when that troponin level is elevated, we're talking 0.2, 0.3, 0.4, and higher, again, depending on the range of your place or facility, hospital, wherever you're working at. The other thing too here is the normal that I've reported is nanograms per milliliter. So you have to be very careful. Is it reporting in milligrams or milliliter or nanograms per milliliter? So be very careful when you interpret these numbers. But troponin that are high, so 1, 2, 3s, 4s, that can indicate that there is damage to cardiac muscle fibers. And the thing about troponins is that the more damage there is to the heart muscle fibers, the greater the number. So a troponin of 5, 6, 7, 8 and higher, that means severe, profound damage to the heart. There are some times where you see that this number is a baseline high. And what I mean by that is our patients have had some sort of muscle damage in the past, and this is their new normal. So we have to be very careful before we go off diagnosing a heart attack in patients with high troponins, because it may be their baseline. Okay. The other thing we do is we trend troponins. And what I mean by trending troponins is that when you come into a facility and you're complaining of chest pain, they draw a troponin level, and then 6 hours later, they draw another troponin level, and then 6 hours after that, they draw a third troponin level, because we want to see if there's elevation. Because as the heart muscle continues to die or become damaged, those numbers will continue to elevate. And so oftentimes you will see that troponins are trended over time. If they notice a significant rise in troponin, these are the patients that immediately go to the cardiac catheterization lab, because there's some sort of heart attack happening right now. Now, the only other asterisk that I would put beside troponin here is that if they come into the emergency room with chest pain and it is already extremely elevated, i.e., the troponin level is like 4 already, they will immediately take them to the catheterization lab, because they are in the midst, in the throes, in the peaks of heart attack. And so they will go ahead and intervene, because once you lose cardiac muscle tissue, you do not regain that function. And so troponins are very pivotal, gold standard when it comes to determining whether or not a patient is having a cardiac event. Okay, and that is it for lab part 2. In part 3, we're going to talk about more of like metabolic and GI types of stuff. So stay tuned.